Assalamu alaikum, everyone. First of all, congratulations to all the organizers for putting together a fantastic meeting despite all the limitations with the pandemic. And thank you for giving me the opportunity to host this. So I'd like to request our panelists and chairpersons, Dr. Azhar Kiani, Dr. Shazad Munir, Dr. Asad Pathan, Dr. Babar Hassan, Dr. Abdul Hakim, Dr. Masood Sadiq, Dr. Asad Khan, Dr. Mahmood Al Hassan, Dr. Vakar Ali, Dr. Nawaz Lashari, and Dr. Wasif Qureshi. So I think quite a few are already online, and panelists in
Usman, I'm just going to call a couple of people over here also.
We have
Usman,
sounds good. Absolutely.
Can you hear me? I'm just going to call a few people here. I think we already have few. Dr. Adnan Amin, if he's around, he can come over. And we already have few. Okay. Okay. Thank you. Go ahead.
Okay, perfect. So we'll jump right into the first talk. Dr. Gilbert Tang's talk, as you know, already is done. We are fortunate to have with us Dr. John Forrest, who has been a very good friend and a mentor for me over the years. Dr. Forrest is an associate professor at Yale University. He's the director of interventional cardiology program there. He's the director of the structural heart disease program there. And he is one of the major authors on all of the core valve papers, which is what we use in Pakistan. So I think very relevant for our landscape. He's also extensively published on TAVR and bicuspid valves. So, you know, he's got extensive experience for the patient population that we have to deal with. And he's going to be talking about tips, tricks, and complications of TAVR. So over to you, John.
Osman, thanks a lot. Really appreciate it. I trust you guys can see my slides there. It's a pleasure.
Yes, we can see your slides and we can hear you well.
Wonderful. It's a pleasure to be here at Pakistan Live. I'm going to talk in sort of the next 12 minutes, do a little bit of a whirlwind, tips, tricks, and some complications, really a focus on two of the hot button issues, and that is bicuspid valves and coronary access during TAVR. So here are my disclosures. So I always like to go through cases. So let's do a couple of cases here. The first, this is a 72-year-old male with severe aortic stenosis, class 3 heart symptoms, and actually a Seaver's type 0 bicuspid valve that we enrolled in the low-risk TAVR study. Patient was clearly low risk for surgical aortic valve replacement. You can appreciate the type 0 valve there and the high velocities across it. I think with all TAVR, whether it's a tricuspid, trileaflet, a bicuspid valve, whatever it is, there's no doubt that the CTA is the cornerstone of case planning. It's critically important to understand your access, understand the distribution of calcium, and how you're going to size the valve. And there's a fair amount of debate in bicuspid valves about whether we should be sizing at the level of the annulus or at the supraannular level. For the low-risk bicuspid studies, we actually sized off the level of the annulus and got really excellent results that mimicked trileaflet valves. And there's a lot of data that's come out that's shown that sizing at the level of the annulus is a lot more reproducible and predictable, and that while you may seal supraannularly, you will always seal at the level of the annulus. And so we certainly recommend to size at the level of the annulus, even when you're doing bicuspid valves, and in this case, a type 0 valve. You know, the next key thing is to formalize your planning going into a case. This is a little film that our fellows make up before each case. And in this case, this patient sized out for a 29 millimeter Evolut Pro bicuspid valves. And actually most of our cases now, we are using neuroprotection here in the US, looking at what the coronary heights are. You know, patient with a normal EF. I think one thing you will appreciate here is it's a fairly horizontal aorta. You appreciate the aorta approaching 70 degrees there. And so before we've even walked into the case, we know what we're going to do. It's a 29 millimeter Evolut Pro using a Lunderquist wire because of the horizontal aorta, aiming for an implant depth of 2 to 4 millimeters. We always pre-dilate our bicuspid valves. I think that's critically important, especially with self-expanding valves. So in this case, we're going to use a 22 millimeter ZMed2, and then have some guidelines for when we want to post-dilate it. Every case needs to start with good access. And I think, what that we often overlooked at, this was actually the access that was initially obtained in this case. And the level of the stick is good, but if you look at the angle of the stick here, it's not going to be so good. We need to use the inline sheath for the Evolut valve. And coming from the side of the vessel, as this does, means that the valve's going to need to make a sharp left turn as it enters the femoral artery. It's going to put you at increased risk for vascular complications. You know, you look at the little X there, that's where the skin has been stuck and you really have entered the side of the vessel. You really want to be sticking here at the bottom of the femoral head, entering like this so you have a straight shot. You may find experiences where the evolute valve can be a little bit difficult to get through the femoral artery. And if you have an angle like this, that's going to be one of the cases where it's difficult as opposed to having a straight shot. As we become accustomed with the evolute valve here, deploying slowly and evaluating the depth is critically important. You can see a nice slow deployment of the valve. The valve does have a tendency to go into the ventricle a little bit. And in this case, the positioning is not too bad, but with the evolute system, we can recapture it now. And I think this is a positioning that while early on with the core valve, we would have accepted it. With the evolute, I'd say you don't need to be this low. You can be a little bit higher. Being this low is going to put you at increased risk for conduction system disease. And if we can avoid that, I think it'd be nice too. So in this case, we recaptured the valve. You can see now starting slightly higher here. We know the valve's going to go into the ventricle a little bit. So by starting slightly higher there, we end up with really an excellent depth. Finally, if we look here prior to our release, you know, a depth of about 1 millimeter or 2 there on the non-coronary cusp. We release the valve. You can appreciate just how horizontal the aorta is here. The valve's almost lying sideways on the AP view here, and a beautiful result. One of the other sort of tips and tricks is I certainly would consider TEE for these cases. When we're dealing with a really horizontal aorta and a bicuspid valve, we often will use TEE, even especially in low-risk patients where we want to get a perfect result. We don't want there to be any paravalvular leak. We really want to mirror results that we see with surgery. And that's what you see here. No paravalvular leak, a perfect implant depth, no changes in our QRS complex. In the end, I think the goal for patients who have a bicuspid valve is to mirror the same results with TAVR that we've seen in tricuspid patients. And that's what we were able to do in this case. No paravalvular leak, a 2 millimeter gradient on cath, an 8 millimeter gradient on the echo, extubated in the cath lab, admitted to the step down and discharged on post-op day 1. I want to move sort of onto our next case here. So this is a 23 millimeter subclavian case that we were doing. I know in Pakistan using primarily self-expanding valves. This is actually a balloon expandable valve that we decided to use here. I'll talk about why. A patient who has a lot of peripheral vascular disease, and so the femorals weren't accessible, so we went with a subclavian approach. Again, CT scanning always the key here. You can appreciate on this patient sinuses of Valsalva that are pretty narrow here, so measuring 25 by 25 by about 27. So narrow sinuses of Valsalva. A coronary height that's not too bad, about 12.4 millimeters. If we look at the size of the annulus here, measuring out at 67 millimeters. And so when we look at valve sizing, it either sizes out for a 26 millimeter core valve or evolute, or a 23 millimeter sapien. One thing that you'll note for the core valve is that if we're going to use a 26 millimeter core valve, it's recommending that we have sinuses of greater than or equal to 27. All of our sinuses are actually just under 27. In this case, we decided to use a 23 millimeter sapien valve, and we did not protect the coronary arteries, thinking that our coronary height was high enough. So here's the valve deployment. In this case, because we have low coronary, because of the small sinuses, we decided to deploy the sapien valve a little bit lower than you might normally expect. A little bit more of the valve into the ventricle. We got a beautiful result there, and you can see on the final aortogram on the bottom right, everything looks pretty good. We took out the sheath from the subclavian and gave protamine, and the patient very quickly became hypotensive. And so our hypotensive diagnosis here is either the patient's bleeding, they may have a pericardial effusion, certainly there could have been annular rupture, it could have been a protamine reaction, it could be coronary obstruction, or it could be valve dysfunction. And so what do you do next here? And I think it's pretty clear that the next step that is critical is to get a cardiac echo. And so we have an echo that's in the room if we're not using TEE. And in this case, you could see that there was significant wall motion abnormalities that were instantly identified by our echocardiologists. suggesting that the issue here wasn't bleeding or an effusion, but was actually a coronary issue. And when we took the guide catheter in, you can see that the ostium of this left main is significantly compromised by the leaflet that's been pushed up next to it. So coronary obstruction in TAVR, there's been a fair amount written about it. It tends to occur in native disease less than 1% of the time, tends to occur more in females than in males, and is a very high 30-day mortality rate. It's important to note that it occurs due to the native leaflet obstructing the coronary ostium. It's not that the valve frame itself is there, but it's the fact that in TAVR, we don't take out the native the native leaflets of the aortic valve. We push them to the side, and when you push them to the side, if you have a low coronary height and a small sinus of Valsalva where you can fill up that space, you can occlude the ostium. Tends to occur the left main more than the right coronary artery. We talked a little bit about the fact that it can occur more with small sinus of Valsalva and low coronary heights. It has a significantly increased frequency when patients are undergoing a valve-in-valve procedure, where the incidence is about 2.5%. With regards to the management of coronary obstruction during TAVR, it's critically important wherever you're doing your transcatheter valve that you have PCI equipment easily accessible. Some of these patients may require cardiopulmonary bypass or ECMO, so having some sort of mechanical support I think is also critical. In high-risk cases, you may want to consider stenting prophylactically and leaving the stent in at the time of the TAVR. TEE, as we talked about before, to sort of give you that instant feedback that you need, is something that we often consider. One thing that can be done is angiography during the balloon valvuloplasty. And if you do that and you see that while the balloon is inflated during your balloon valvuloplasty, that you've obstructed the coronaries, you want to reconsider your plan if you're not going to protect. And it's also, I think, critically important to ask up front, is SAVR potentially a better option for these patients who are at very high risk for coronary obstruction? Because of course, with SAVR, you'll be removing the native valve leaflets. If we go back to this patient, the blood pressure actually improves significantly often when you get the guide in place, because that pins the leaflet back down. And so the blood pressure improved with the guide in place. We were able to stent with the 4.0 by 12, a nice short
2 minutes
stent there. And the patient had excellent recovery. And here you can see the results there. So clinical data showing that it's feasible, but that being said, it can be challenging and it's not always easy. A couple of tips and tricks there. Consider using JL or JR catheters. Downsize the catheter by 0.5 centimeters. Aim for the frame waist. Use guide extensions liberally, and remove the catheter over a wire. I'm going to just cut through these fairly quickly, but downsizing allows for more maneuverability. Guide extensions, especially when you can't selectively engage the ostium, may be quite helpful. And the reason that we remove the guide catheter over a wire is if you don't do that, there have been cases where when you pull back on the guide catheter, you can actually get it stuck in the V of the frame of the core valve, making removing it very difficult. So this isn't something we usually do, removing the guide over the wire, but I'd highly recommend it. Here's a last example, a patient with an inferior wall STEMI. A year after the TAVR, you can appreciate you're only able to inject sort of outside the sort of offshore, as it were. But you're able to wire it from offshore. You're able to put a guide extension down, perform a thrombectomy. And actually, after the guide extension was down, it pops in and you're able to get an excellent result there. So in the take-home points, coronary obstruction during TAVR is rare, but be prepared. We talked about some of the risks. Engaging the coronaries through the every frame can be done, but with a high rate of success. It may require some modifications that we talked about there, including offshore wiring, the use of the guide extension. And it's all critically important to note that valve-in-valve procedures increase the risk of coronary obstruction, especially if you're doing a TAVR and TAVR, something to be considered in low-risk patients. Thank you very much.
Thank you, John. Great talk, as always. I think we have a few minutes for question and answer. So anyone on the panel have questions for John? I know I have a couple.
Hey, John, this is Wasif Qureshi. How you doing? Just a couple of questions. One is about the S3 you put in the 23 millimeter with the access being a little difficult. Did you have any access in the groin ready for ECMO and anything else later on if you were going to have trouble, or because peripheral access was difficult for the TAVR. So how would you get your ECMO sheets up?
Yeah, so, it's a great point. So we plan what we're going to do for each case. So in a case where we don't, that patient doesn't really have a peripheral ECMO option. So in a case where we don't have a peripheral ECMO option, we have a pump team on standby if needed. So we let them know sort of what is our backup plan for all of those. The rate's incredibly low. We're fortunate to have a good number of resources. So, that's a case where you can't do ECMO. ECMO is our standard thing that we have in the room. But in a case where you can't have it, you're going to have a backup. So in that case, we have a pump team on backup.
So I have a question about valve sizing. What I've found is if you size to the annulus with core valve or Evolut platform, and there's a discrepancy in terms of the size at the level of the leaflets. So say the annulus says you should be a 29 valve, with the leaflets it's more of a 26 valve. You end up putting a 29. It actually affects the expansion of the valve at the leaflets, where you may see a fold in the frame. I don't know if that's ever happened, and how does that affect the long-term durability of the valve, and how do you address the size discrepancy?
So, I think the times where it's smaller up there is certainly of a concern. I have not, we've seen, Osman, the fold in the frame if you don't do a good pre-dilatation. So if you don't pre-dilate it, you can see that there. I've not seen that there when the valve's been well pre-dilated. But I think it's also important to note that, not all valves are the same. Not all bicuspid, not all tri-leaflet valves are the same. Raj Makkar and his group have done some really nice stuff looking at the extent and the distribution of calcium in the leaflets. And it's probably actually that distribution of calcium more than the number of leaflets that's going to affect it. And if you have a super calcified raphe, it may be very difficult up there. And in certain cases, sometimes what we'll actually do, you can size it off the balloon a little bit. If you take a small balloon and you seal everything up perfectly with, say, a 22 balloon, you probably don't need to put in a 29 valve. You can probably get away with a 26.
There is a question here from the audience, please. Go ahead.
Hi, my name is Ali Raza, and my question is regarding the commissurial alignment of the Medtronic valve, because if you do the commissurial alignment, Medtronic new valves have got a system like that, and you can access the coronaries as well. We used to do in leads a lot of valve and valve. We didn't use TE much as well, and neither the pacing wire as well. We used to do the wire pacing through the same Safari wire. That was one of the other techniques which we used to do. So what's your thoughts about those two things, about the commissurial alignment of the Medtronic valve?
Yeah, so Gilbert Tang has been one of the key people driving that, and I know he was scheduled to give the talk before, which is I didn't talk much about it, but I think it's something that absolutely we should be doing. If you put the flush port at 3 o'clock when you're going in with it, if you look at the hat marker when you come across, you should be able to line up your commissures. If they're not, you can bring it back into the ascending aorta and make some modifications there. Gilbert's written some really nice papers on it. And for those not familiar with it, I think it's a critically important thing to understand when you're doing these. And we really want to try to line up the commissures. If your commissures are lined up, it's going to make coronary access much, much easier after the valve's been put in.
I have a question. So, Dr. Forrest, what do you think about routine use of anticoagulation after a TAVR? I know the data is sort of in between somewhere, but like cases like valve and valves, and like cases like where you have put a core valve in something like a tight sinus or low STJ, would you consider using anticoagulation without any evidence of thrombosis up front?
Yeah, so the question of antiplatelet and anticoagulation after TAVR is always an interesting one. I think, if it's in a native valve, we've actually moved now to just single antiplatelets instead of dual antiplatelets. And I think that, the question of should you give a short duration of an anticoagulant 3 or 6 months after doing a valve and valve is still out there. We do it on occasions when we have high concerns, when we think there's a low risk. A lot of these patients are elderly though. And so I think until we get more data, it's hard to say. We sort of do it on a case-by-case basis, certainly not as a routine anticoagulation in all valve and valve patients.
I have a question. It's more of a philosophical thing that, with the ever-expanding indications for TAVR and the fact that younger and younger patients are getting TAVR, what's the sort of surgical outcome when these prostheses start to fail or malfunction? I mean, is it going to be a nightmare for the surgeons to, do a sever after a TAVR, or I mean, what sorts of scenario do you foresee?
Yeah, so another, I think that what do we do when the TAVR valves fail? I think it's something that you need to be thinking about, especially in very young patients. There's been a good amount of data that's come out recently on the TAVR explants, and certainly the results of those are higher risk than doing a surgical aortic valve in a native patient. We've done a number of them. I think it's critically important that the surgeon be familiar with TAVRs and with anatomies, some of the ways that you'll actually take those valves out. And for the nitinol valves, you want to sort of pack the chest with a little bit of ice in there, which allows you to manipulate the valve when you're taking it out more. It's an area that we need to consider. There's actually a question in the chat, a similar thing, that we have to worry about, especially if we're doing a TAVR, and TAVR is the native leaflets obstructing the coronaries. There are some techniques like the basilica and other cutting techniques that are out there for leaflet manipulation that I didn't have time to go into today. It's another option if you don't want to sort of snorkel your stents out there. Can be done elegantly, although it's challenging at times. And I certainly have seen times where it's been attempted and still ended up with coronary obstruction.
Usman.
All right, great. Bashir, are we ready for the live case?
Yes, we are ready.
Okay, John, thank you so much. Okay, yes, I think we can, as we're setting up one more question, we can squeeze it in.
You said that those patients who are at high risk of coronary occlusion.
Can you speak loudly, please?
No, it's okay now?
Yeah.
The patients who are at high risk for coronary occlusion during TAVR, you said that you check them with balloon dilatation initially and see if they are prone to occlusion, so you go for SAVR then TAVR. So how to assess this with the balloon dilatation? Because when you dilate the balloon, you will be unable to see. So how to assess during balloon dilatation?
So not balloon dilatation of the coronaries, but when you're pre-dilating the aortic valve and the plan for it.
BAV, how to assess during BAV the leaflet, the native leaflet? See.
So when the balloon is up during the BAV, making sure that it's below the sinotubular junction, and then injecting contrast while the balloon is up. If you inject contrast while the balloon is up, it's pushed the native leaflets out to the side. And if you see that you've now obstructed flow down the coronaries in that case, you want to be really, really careful about moving forward with it. So we tend to do that in cases where we think we're going to be okay, but it's on the borderline. And if we obstruct the coronaries during the BAV, we say, you know what, we're not going to be okay. Now, similarly, if you have really low coronaries and small sinuses, don't rely on that BAV. If the BAV looks fine, I still would protect those arteries. But in times where you're sort of borderline and you think you're going to be okay, that's one last step that we do before we just put the valve in.
Okay, great. Tons of questions, John, but fantastic talk as always. Unfortunately, we're limited for time. I'm going to ask Professor Nadeem Hayat Malik to come on the stage and moderate the local live coronary case from OMI.
Bismillahirrahmanirrahim. So we'll start off with the live case, which is being done by Professor Nadeem Rizvi at OMI. So can you hear us, Nadeem?
All right. So this is a 60-year-old female who's a hypertensive and diagnosed with unstable angina. And she's now got 2 to 3, for the last 4 months, she's been having 2 to 3 class angina, and she was had a cath on the 8th of July, which showed what we are. Abhi one pe chale jaye, cath pe, one pe. So we'll just go through the file and then go through the steps. All right. So can you see the screen? We want the cine screen.
Yes, we can see it clearly. The ostial LED.
Right. So this is ostial LED. It's LED is diffusely diseased. And we've got next. Okay. Okay. All right. So the LAD is severely diseased, subtotal in the middle, filling the right. Next. You can see it's a trifurcation with a ramus, which has got severe disease and probably a moderate disease in circumflex. Next. And the right's got a critical subtotal narrowing, two areas. One is subcritical, subtotal, and there's a moderate to severe before the PDA. And if you look at it carefully, the LED is also filling from one of the collaterals here. Next. So this is where we stand, and we've done this off camera. So what will be the plan here? The LV is around 30-35%. Nothing is akinetic. There's a hypokinetic anterior and lateral wall and anterior septum on an echo, and EF is around 30%. And she's got limiting angina. So what would be the strategy in this case?
So maybe we can, we can ask the panel, how many people would go for surgery? Is the patient a candidate for surgery, or is it a surgical refusal, or has she sort of, you think she's not suitable? So how many people, yeah. Or what's the syntax score like, and
well, we haven't calculated the syntax score, but you can see it will be somewhere around in the early 30s. If you look at it, left main also involved, circumflex is a bit. The problem is that she's 60-year-old and she's a frail lady. She looks she says she's probably 70, and she's probably refused cabbage, and she's been shifted here from another institution with a view that she does not want cabbage and whether she is a suitable candidate for PCI. So obviously with these two main vessels occluded and limiting angina, she can hardly walk to the toilet, I'm told, without angina. So we need to revascularize her. So she's a candidate for PCI. I think the debate about PCI versus cabbage is long time. Let's talk about the strategy. I'm sure a lot of panels will say that she should go for cabbage. Next.
So what's, the other question can be that which vessel do you think is culprit, and which vessel should be done first? Should you do the most difficult vessel first, or would you rather do because there's collaterals to the RCA from the left and there's collaterals to the LAD from the right. So it could be argued both ways. So I don't know.
Can I, Nadeem, just carry on and show you what we've done?
Yeah,
and at each step. So
yes,
I decided to take the right first because it was the whole PDA was filling from the left, and it was a critical and easier lesion, I suppose. Next. So we just put a whisper. Next, put a stent, and then looked at it, optimized it. Next, aram. Next. So stop. Now. There is a distal lesion in the PDA. Now, if you look at it, if you look at the Finesse score, with that 3.54 vessel, it's all diffusely diseased. So obviously that lesion I am comparing to the open artery in the middle, and that is around 70%, I suppose, because with the large 2 PLV PDA. So I am going to treat that as well. Next. And I looked at it in another view, so I put a stent there as well, a 3 millimeter stent, then optimized it with 3.5. Next. 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 So it turns out to be a large vessel. There is something in the, the stent in the mid part. There's a bit of accordion type of effect, which next. But there was disease there, so I don't want to take a chance. Put a small 4 millimeter there. Next. And optimize the whole thing with high pressure 4 millimeter balloons. Next. So this is what we have. Stop.
That's a great result for the right.
I guess
I have a question.
Which vessel is
covered and diseased. Next, last shot of the right. Stop. You can see it's a large.
Yes. Yeah, carry on.
Interesting part is here. Now, what is the strategy here? So next. So that seems clear, wire, balloon. Just come on, next, 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 next. All right, so this is where we stand. Now, we ballooned it, opened the LED. Now, what about this trifurcation? I use 6 French. Usually, I'm using 6 French. What would be the next step? Because obviously, you can nail the LED, but that's not recommended. There's some disease in the distal left main. So we need to go for the left main now. So it's a trifurcation left main. The LED is now open. So what would be the next step?
So would you wire the intermediate vessel at this stage?
Yes, next step. So we wired the, stop, go back. So you probably, yes, I'd wire it, but let's debate the strategy. If you've seen the cine, then my own view would be, in the interest of time, that I would do a sort of a decay crush, nano crush here, trying to put a stent and crushing that stent of the circumflex via balloon in the ramus first, a 2.5, and then crushing the stent further with a 3.5 next to it. So this is where I just used just a little bit of couple of struts in the left main. Next.
So this is a 3.5 stent?
This is yes, I think it's a 3.5. But in any case, I'm going to do it with a 3.5. I think it's a 3, probably. I didn't want to use a large. And then I didn't pull the balloon back. I just crushed it with this 2.5. Next. So this is the result now. Next. Next. So now what I do is we recross. Next. Sorry, I crush now the stent, keeping the balloon in the left main, but just crushing that part of the anti-carina part of the circumflex stent. Next. So this is what we do with a 3.5. I could use a 4 here as well, but I use a 3.5 for crushing. Next.
Dr. Nadeem, it's Usman Fahim. I'm just following this.
So this is the last shot. This is where we are now. Okay, Usman.
So I didn't appreciate a lot of disease at the circosteum. It looked to me that the disease was in the prox to ostial LAD and the ostial ramus. So did you consider just stenting left main to LAD and then bailing out the ramus with just balloon angioplasty?
Yes, we were debating that, and in my little experience, I think if I had, there's a pretty mismatch because there's a ramus, there's a large circ. The LAD and the left main is quite a mismatch, so I would have to, let's say, use a 3.5 around, and that would have occluded the circ in my view, the ramus, and also shifted the plaque and the carina towards the circ, which was around, in my view, 40%, didn't IVUS it, because I'd already made up my mind that I'm going to do a decay crush in this, because the provisional strategy in this would have probably not worked, in my view. I may be wrong. Yes, Nadeem, you are right.
Nadeem, quickly just ask other panelists' view what they would have done, just quickly. Maybe Wasif, do you want to say what would you have done in this case?
Yeah, so thank you, Bashir. This is Wasif Qureshi again from the US. I think this is a very complicated case. I think that in my opinion, would have sent this lady for bypass surgery because putting stents in her is probably going to be short-lived. The fact that she doesn't want to go for bypass, I think you need to make it simple, and I don't think you need to make it complicated. I think IVUS has to be done in this case because without IVUS, you don't know what size stents you're going to put in. You don't know the size of the left main. You don't know the size of the LAD, or as Usman said, the size of or the amount of disease you have in the circumflex. And I would keep it simple. I would just put a stent in the LAD and then do a provisional balloon of the ramus and get out of Dodge as much as possible.
Okay, thank you. Dr. Kiani, what would you have done? You are mute. Can you unmute yourself, please?
Yeah, I think I would try to keep it as simple as possible, not to complicate it any further. But once you are in, I think then the way Nadeem has planned it. He should go ahead with it. I think now once he's there, so he should stand from left main to LAD, where I think that's the first thing to do. And then if there's any issue after that, then he can handle it accordingly. But as for, I think what we will do here is that in such kind of case, we always go for the cardiac team and then seek the surgical advice. And then once the cardiac team is there and the patient refuses the surgery and goes for another option, then we go for the intervention. So that's how it should be. Now he's in. I think he should finish it. Hopefully, I think successfully.
Hakeem, are you there? Abdul Hakeem? No, he's not. Okay, okay, go ahead, Nadeem. Sorry, go ahead.
Yeah, so I think the Wasif's well taken. I mean, obviously, she's on the table and I'm doing the case, so she's been counseled properly. She has shifted from an institution where there was cabbage available, but she refused. I think, yes, that is a different debate. But as far as the other questions concerned, 90% of the labs don't have IVUS. We do have IVUS. It's not yet opened up, but I've got enough experience with IVUS. The problem is that, yes, it's mandatory in some views. I personally don't use it too often unless I have a problem where I can't understand the nature of a complication. Now, in this case, I'm going to do a 4-millimeter balloon in the left main. She's a lady who's 5'1". I don't think that her left main would be bigger than that. If you do IVUSs, you have done it last time. There was a 6mm 7, but ended up with ballooning with 4 or 4.5. So options are limited. The maximum you can go up is 5. So I think that what I'm going to do is fix the LAD with a 30mm stent and overlap in the LAD rather than in the left main. I'll see how the lengths go, but there's a significant, the LAD is probably 3.5. I don't remember the other point, keeping it simple. I think losing, if you are going to do it, there's enough, I mean, the syntax data, the sub-study from Syntax data, even with a Texas stent, if you compare it, the recent thing is that they looked at a long-term 10-year results. If you compare, even in the higher syntax score, the PCI was better off than cabbage in patients who were totally revascularized. I mean, this has just come out recently. So I think that was with Texas stent, and we are using Onyx here in this case. So I think the third generation stents, but again, it's operator dependent. As long as the patient is counseled, I think all of the views that the panel has given are well taken and are quite logical. But from the technical point of view, I think just for the debate of it, the various strategies, one could do Colot and something. I think that's what we, but in our environment, 90% of the labs don't have IVUSs, or maybe 95%. So what do? I mean, these patients can't go to US or UK or come to other hospitals. So they need to, the fellows and others need to understand that, yes, they need to be in their training exposed to IVUSs and where to use it. But mandatory in every single left main, personally, I don't accept that.
In that case, I think your eyes are your IVUS. I think, yeah, then if you don't have IVUS available.
Two questions, it's Asad here. One, what size stent are you going to use in that LAD? It doesn't look like a 3.5, which you need if you are going to come back into the left main. And secondly, because you can't go above.
I'm going to use a stent because I've got 3.5 NCs here. I always use a slightly undersized, and then, but I think it will probably be a RO karo.
And are you going to cover the entire left main?
No, I'm not going to. This stent is going in the LED. I'll see whether I need to. Yes. I'm going to cover. I ballooned the whole of the left main, so I'm going to do the cine.
So the ostium, you'll start off from the ostium of the left main and go into the LED, is it?
That's the advice that I to give me epicaudal. That whether I should do the overlap in the LED or do the overlap double. I would like to leave the overlap in the thing in order to keep it simple. I've rewired the circumflex. I've done the first case. If you go back to them, go back. Sorry, cine दिखाएं. Yeah. So पीछे जाएं. पीछे. All right. Next. So this is going through the proximal strut. The wire. Next. So this is opening the strut. Next. Next. So this is the case, first case. Next. And this is where the stent, I'm going to stent the, I think I'm going to overlap it partly next. Aage jaye. Die. Yeah, I think I'm going to leave the here and probably overlap it here. Let's see if I can manage to do this. Right, just a bit ahead. Yeah, yahan karen. Karen. 4, 5, 6, 8.
So you are planning to do, why are you going to overlap near the ostium? Won't you like to keep the stent a little bit further down and overlap in the proximal LAD instead of overlapping in the ostium, because that's going to close down the ramus?
Yeah, I think you're right. I probably should have gone a little bit ahead, but I think it should be okay. Let's see. Yes, that was the plan, but I didn't want to go too deep into the LAD. I thought I'm going to just do a small overlap. It's not too big. I'll see. I'm going to do the ramus and LAD ballooning, etc. So I think let's see. Yes, I think quite well taken. I may have probably should have gone another 5 millimeter. But
well, you see, with the trifurcation, you have to devise your own strategy, because there's no written strategy for a trifurcation like this. I mean, you have to really, devise a strategy which works for you. I mean, the decay crush and everything works for 2 vessels, not for 3 actually.
Okay, so now this is the situation. Okay, panel.
So, yeah, the LAD looks fine and the intermediate vessel looks fine.
I think if you are sure that you have nailed the ostium, then you could have probably post-dilated and left it alone, but you have to have IVUS or something to really make sure that ostium is covered. Otherwise, you have to put another stent to go into the left main.
Even if it's been nailed now, there's been ballooning done in the left main, so I guess you have to cover it all the way back at this point.
I think the left main will have to be stented now, definitely.
Yeah, you're right.
Left main to LAD stent, yeah, that's what you need now.
How do the reason why I put it at the ostial nailing is, I had at the back of the mind, I know it's a bit controversial and people will start telling me about that I have to do IVUS and all. What about just stenting the left main till the POC and just spreading it out into the POC and not going into the LAD with that stent? Just trying to...
Yeah. How will you be sure that there's not a couple of millimeters gap between the LAD stent and the left main stent then? Would be difficult to be sure actually.
This is where imaging can help, I guess. That's always.
Yeah. I think because you definitely missed the, you are just at the ostium and angiographically it looks good, but I mean you cannot be sure about it. And if you are unsure, then it's better to overlap.
Agree.
12 millimeter, 3.5.
Nadeem, I would go with the plan of Dr. Bashir Hanif, that you push it a little further and then you overlap the stent from left main to LAD, so that it will come at the bifurcation. So that's the, I think, safest thing to do.
Yes. Yeah, that's what we are suggesting. Yeah. Stent from left main to LAD across the circ.
All right, okay. अब अजहर साहब ने कह दिया तो अब वो तो कुछ और हो नहीं सकता.
You are the best judge over there. You are the one who's responsible for the patient. So do it whatever you feel is necessary.
So I think that this stent from the
he's trying to involve you. He's trying to involve you into the responsibility as well.
I just want to make a comment about putting a stent from the left main into the LAD. You're going to jail a big circumflex. And what is going to be your anticoagulation strategy for the long term in this 60-year-old patient with an EF of 35% after putting in multiple stents?
I think this is a decay crush. I was already the left, the circumflex has got a stent in it. It's a 2-stent basically strategy of the distal left main. So the anticoagulation will remain the same. Maybe I don't like ticagrelor because a lot of my patients have had breathlessness, and Plavix works as well. But in this case, probably ticagrelor, and that will be the anticoagulation strategy. Maybe 1 month of high-dose aspirin, 300 milligram or 150, and then 75 milligram and ticagrelor for another couple of months, and after 3 months, maybe months.
Yeah, with
I don't think that
ticagrelor, you have to use low-dose aspirin. You can't use high-dose aspirin with ticagrelor.
Yeah, very true.
Used to ticagrelor, so yes, that I will use. What's the evidence for that?
Dr. Nadeem Rizvi, can I ask you,
bleeding
what
risk
sort of
is
stent
considered to
are
be
you
high.
going to use for left main stem? What size?
Yeah, so because Dr. Kiani and my senior colleagues, Dr. Nadeem and Bashir have all, so this is 12, 3.5, 12.
So this is an onyx?
Yeah, this is an onyx single sensor, aleocranial. So I'm going to overlap it, and let's hope that the ramus doesn't go down, because then I'll have to go off camera and let you.
Would you leave your ramus wire there? I generally, if I'm jailing a wire behind 2 stents, I'm hesitant to do it. But would you leave the ramus wire, pull it?
Yeah, that's a good advice. Yeah.
I'll leave the ramus wire. Why do you want to pull the wire? Aage jo. So
Because 2 wires will be jailed.
Well, generally, if it gets jailed between 2 stents, it can be hard to remove.
Right. All right.
Well,
so
you
I personally, I don't know whether I've not IVUSed it, but my view is that there's no strut in front of the ramus at the moment. There's no metal in front of the ramus. The carina shift will occlude the ramus once I deploy this stent, maybe, but there's no strut. Niche aa jao, epicaudal. So
Well,
in my view, I think
that the ramus wire is too far down. Maybe you can pull it slightly to make its removal easier, and it's got a bend at the end which could create problems. So maybe you need to pull it a little bit and bring it closer to, yeah, that's where it should be. The radiopaque portion should be just, just at the end of the stent.
all right, I've never had a problem unless it's going to happen now on live, with whatever wires there are. Yeah, kar do. 4, 5, 6, 8, 10, 12, down.
I mean, the length of the jailed wire is not going to be too much, so I hope it will come out easily. I mean, but it is a concern, and sometimes wires do get stuck or broken. I mean, that's always a possibility. But then this question of anticoagulation was being, antiplatelet medication after this sort of procedure with 4 to 5 stents. And I think we can have the opinion of other people, because there is some evidence that with more complex bifurcations, you maybe need to anticoagulate more vigorously than as compared to sort of a simple 1 to 2 stent strategy. So I mean, the other panelists can also, give their views on that.
I think.
Yeah, now.
What I was going to say was that definitely I'll keep them on dual antiplatelets for more than a year, probably a couple of years, especially if it's a young patient with not much bleeding risk, and definitely ticagrelor would be my option. There is some people might use apixaban, low dose and stuff, but I think ticagrelor, if the patient tolerates it, should be good enough for this sort of stenting.
So I think the main part is over now. I just have to finish off with rewiring and the second case, and the ramus seems to be open despite this center karo. So I'm going to just take a picture and see what the situation is. All right. So, sorry. ठीक हैं आप? ठीक हैं? बस ठीक है. बस 5 minutes. So now I think it's a matter of I can do a triple case or I can do a double case. What do you panel say? I mean, this is all 6 French.
No, I think the ramus is a small vessel. You don't have to do a triple case. Just do the double case and post dilate and see the result. If the flow is good, then I would leave it alone. I wouldn't disturb the stent starts just for this ramus.
Yeah, you can maybe just balloon the ostium with a small, say a 2O balloon, just to increase the flow, and and then just do a normal kiss and then a pot.
So Nadeem, we have 10, 12 minutes left. Do you want to go to the other lab to show what's going on there?
Yeah, please. So I think if we can go to the other lab.
So just tell them, please.
So basically, I've put the wire. I'll see if I can.
Not a good idea to say, oh.
Hello, can you hear us? Suhail Aziz Sahib and team.
Assalamu alaikum. Nice to see you guys. It's a relief to hear your voice. I hope you can hear us.
Good to see you and Nadir. Busy at work.
Hear us?
सुहेल, आपके 15 मिनट नदीम ने ले लिए हैं, आपके पास 12 मिनट हैं अभी.
Yeah. We know you can do it in 11.5 minutes.
No, he can do it in 5 minutes.
Yes,
no issue.
Of course. With time for discussion.
The groin, he has a diffuse peripheral arteriopathy. Can you show us this? Can you please show us this? Can you show it, please? Can you see the angle? Yeah.
We can see it, although not very clearly, but yes, we can.
So, if they could only focus on one screen instead of both, we may be able to see it better.
सिर्फ राइट वाला नजर है। नहीं, कौन सा कैमरा वो है? उससे कहते हैं जूम इन करके दिखा सकते हैं। सिर्फ राइट वाली।
Just show the live one, not the frozen one.
आपके पास टाइम थोड़ा है।
ये दिखा रहा है जो चल रही है, ठीक है? हाँ। Okay, so she had from interior changes.
Can he sorry, Suhail, can he focus on the right screen? Yeah, that's better. Maybe let it increase. And no, center it, please. Go a little bit above also. We need to see the whole thing. Higher, go higher.
Go higher, camera.
Yeah,
yes.
Yeah, that's better.
Yeah, better.
Okay.
Yes. Please go ahead, Suhail.
She's diabetic. She came with acute syndrome about a month ago, and there was this LED, and somebody tried in another hospital to do this LED, and they kind of went subintimal, they went all the way down, and there was like no flow, and so she's back here, and we can see a scene minus, please, one scene minus, please. Spider view. The RCA shows a very large RCA multiple vessels with diffuse disease distally, but there is no proximal lesion which can be targeted. This is the entire system which you need to focus on. You can
the camera is drifting, please. Kindly focus on the camera. Okay. So what were you saying about the RCA?
Dominant. It's large, it has multiple vessels with diffuse disease, but there's nothing which anybody can do about them. It has to be managed medically. And so we have to focus on the left system. You can see, there's a 7 French guider which is sitting there. We just saw the RCA and we took a shot. Can you go next, please? Can you go next, please? Can you go next, please? And we took this double stick, and it doesn't really show the left system too much, but we think that now come back to the next please. Next, please. Next, please. And now, next, please. But एक और भी है. Yeah. So here you can see that there's the LED goes into this big diagonal, and it has a TIMI1 flow into a very thin vessel LED. And so what we're hoping to do is that we want to get into this LED, and we'll probably do a bifurcation because it's a very large diagonal. And once we've done this bifurcation of this LED, it seems subtotal. It has a failed attempt before. They could not cross the wire. They went through the wire and found a false crack. with a Gaia second. We're hoping to get across this time and go minus, please. One minus, minus, minus. We see minus, please. Yeah. And there's some disease in that circumflex. There's a moderate disease of circumflex, which has more disease distally. And our plan is to just focus on the LED for the moment and do bifurcation. And there's a lot of diffuse disease in that circumflex. And in some views in the previous angiograms, we found that the ostium of the circ was moderate. So we're hoping that once we fix this LED, we can then come and fix the circumflex at a later stage. That's the plan right now.
Yeah, the LED seems to be a very diffusely diseased and a small caliber vessel actually. I mean, I don't know whether it's...
No, I'm not sure this is LED or not. Need to see the cranial views. Could be diagonal, I don't know. We need to see cranial views, at least in this view.
I think it's going down to...
Yeah, LED is going down. That's diagonal.
Yeah. No, this is the LED, but it's a very poor vessel actually. I mean, it's really dismal.
Underfilled probably.
We're going to show you some RA centerpiece, another RA panel for the LED. Picture, please.
Yeah. So we can see the small LED. Yeah, very small.
I think it's underfilled probably, may not be that small. The wire is in the diagonal.
Yeah, maybe it might grow after the balloon.
Yep. And so that's why we're here. So what do you think is how would you like proceed with this?
So which wire are you using for the LED?
We are now first going into run-throughs. One of them is on a microcatheter. One is on a microcatheter. Once we get the micro closed, we will exchange one of these run-throughs with Pilot 200 and try and find our way into the LED. And we also have unfortunately, there's only one pressure in this lab, and we've got two lines, so we can use only one pressure at a time. So we think that although there's some integrated flow, but if we occlude this, then there'll be difficulty in finding the channels. Then we'll have to give a double injection. So we've got two sticks into a groin. With the arteropathy, it was quite difficult, and so we'll just see how it goes. So
Dr. Suhail, can you do you have a double lumen or a Supercross 120 or anything like that in the lab?
We had to Supercross. Yes. But I think what we'll do is we're just gonna put both these wires in the diagonal, please, and then we can pull back from the diagonal AP, please. And once we get a wire down, then we're going to place it with the 200 and pull back and try and fall into the LED. That's the plan. Let's see how the plan goes.
Yeah.
It's more like a Napoleon Bonaparte's battle plan, which is basically let's turn up and see how it goes.
Dr. Suhail, this is Wasif Qureshi from the US. Do you have any other wires other than the Pilot 200 which you would start off with, or you're just going to go to Pilot 200?
We would probably prefer a fielder, but I think I need a little more force in this, and I need to have more control, and maybe this would be a little better channel for an XP3, but I chose a 200. I'm sure lots of people start with an XP. And you know, when you if you can show this, can you show this, please? Can you show my hand?
What about using a fielder in this situation? Would you be comfortable or no?
Show my hand. Can you see my hand? You see, it's very important that you when you pull back these wires, you must feed water there, otherwise you suck in air. That's a very important step you need to do. Can I have 200, please? That's fine.
नहीं मैडम
आप इसका 10,000 पूरा कर दें. We're having 10,000 करें पूरा जल्दी. We're having a problem with the ACT. We've given us 7,500 ACTs, doesn't seem to rise.
Pilot 200.
Pilot 200. Yeah. And we're hoping that if we get into the LED, inshallah, then we'll do a DK culotte for this patient. वैसे सी to match. Yes, 10 पूरा कर दिया. Thank you.
बहुत छोटी LED है. I don't know, those stand डालने में चाहिए. I mean, this is a problem with some of the patients who tend to have very small, diffusely diseased vessels, and sort of doing bifurcation procedures on such patients is a nightmare, and the long-term results may not be, as good as they are in sort of larger size vessels. So it's quite a difficult case to start with.
देखें ये छोटी हो बड़ी हो तंग उसी तरह करती है.
So you are going ahead with the pilot 200.
Once the general decides something, he does it.
For some reason, I think I need to be more. Gently, the hands can handle these vessels while check these.
Oh, there's a difficult wiring because you can see that he has to go into the diagonal and then pull it back and see whether the tip falls into the site of occlusion. So this is definitely a sort of nightmarish.
I think sometimes if you have a dual lumen catheter, you can use those to try, that improves your angle of approach to where the LED was.
Asad already mentioned, but unfortunately, I don't think they have that.
Yeah.
Well, did you say, was there any dissection before, like in that LED, or?
This attempt to try Gaia. And
okay, I think we are out of time for transmission, so you can keep working and maybe show us or tell us later what happened. I don't know if Nadeem is finished, so we can maybe quickly see his last image after post-dilatation, and if they can switch it over there quickly, please.
I can understand, so I think we're going to have some doing here. You'll have to switch to the
Thank you very much, Sohail, for an excellent demonstration of wiring and how to plan a difficult PCI. So you carry on, and we'll go over back to Nadeem Rizvi and see what result he has in the trifurcation. Over to Nadeem Rizvi.
Thank you. Thank you. Bye-bye.
डबल ह्यूमन कैथेटर हमारे पास होना चाहिए ट्विन पास.
So we can.
Will anyone use a floppy wire like Whisper in this sort of a patient?
Whisper for. I mean, the thing is that he thinks that there is a sort of subtotal occlusion there, and it's I'm not sure whether the Whisper would cross through this. This looks like a difficult lesion actually to cross. So we are all keen to see the Nadeem strategy for trifurcations, because there is nothing written in the book about it. So you can devise your own strategy, whether you want to put in 3 stents or 2 or 1 or whatever. I think it looks all right.
I think left main, I don't know, probably looks little smallish. Again, if you don't have ideally there should be IVUS, but if there is no IVUS, I would probably take a little bigger balloon to, I don't know.
Can you hear me? So this is the final result. Have a look at this. I have done a, I removed the ramus wire, did the LED optimization with an NC, used a 4 millimeter balloon in the left main and 8 millimeter stent. So this is the final result here. I think angiographically it is okay. I went high pressure in the left main. My own view would be, if you IVUS this, you might see the left main stent strut across the ramus, but you won't see a double layer. You won't see a double layer because of the mini crush that I did. The danger in that was that I missed the ostium of the left circumflex. So I have to, in certain angles, you know, this is not an exact 90 degree, it is slightly, so I think the left main part of the circumflex stent, at least a strut would be going into the left main. So, and then I have covered the whole of the left main into the LED overlap. So I think this is all metal, and still the only issue why the ramus is open in my view is that there is no double layer. If I had done a full crush, then probably there would be a double layer, and probably the ramus would have gone. If you can go LAO caudal.
Yeah, Nadeem, overall looks excellent result. The only thing I was wondering, that left main looks a little bit, I don't know, smallish as compared to if you circ, ramus and LED. If you don't have IVUS, I would probably either take 4, 5 or even 5 in the left main. This is what I feel.
My question is that I can do a 4.5, 8 millimeters or 5 millimeter balloon. I don't think that will harm the patient.
Yeah, I would say definitely go higher than that, because if you look all three, if you combine maybe 3 as circ, 3 of LED and 2 ramus, so it's 8 into 0.7, it's like significant. Yeah, anyway, I think we are short of time. Thank you very much. Looks like a great case.
Yeah. So thank you very much, Nadeem, for an excellent case and a difficult case to start with, and finishing off with a very beautiful and excellent result in the short and long term as well. Thank you.
So now we should continue with our structural talks, and I believe we have Ali Nasir Zaidi online. Ali, are you there?
Hi, Assalamualaikum, Usman. I am.
All right. So Ali Nasir Zaidi is currently an associate professor of internal medicine and pediatrics at Mount Sinai in New York. He's also the director of the Mount Sinai Adult Congenital Heart Disease Center. Well published on all things adult congenital, but especially on atrial septal defects. And so he's going to be talking to us about the evaluation and indications for ASD closure today. So over to you, Ali.
Thank you. Assalamualaikum, Usman. So I am going to start. Let me see if I can share my slides here. Can you see those?
Yes, we can see it and we can hear you well.
Perfect. So let me start. So what I will do is, just as a background, I'm an adult congenital physician, and I'm not an interventionalist, and certainly not a coronary interventionalist by miles. But what I do is ACHD and focus on imaging and a lot of pulmonary hypertension. So what you will see is really a flavor of how we look at ASDs in adults. So this is adults that we're going to be looking at. So what I've done is, let me see if I can move this around, is move the words around. We're first going to talk about indications, and then we'll talk about evaluation, and we'll sort of take it from a non-invasive approach and go forward. The way we'll do this is the following: a little bit of background about ASDs in adults. What are the indications, which is really what I was asked to speak about. The evaluation prior to closure. What things do we think about before we start closing atrial septal defects? And this is not just transcatheter closure, just as a overall picture. It's going to be all sorts of closures, surgical, transcatheter. I'll walk you through an ACHD case. That's probably the best way to do this, is someone who walks through the door. And then a little bit about pulmonary hypertension and hemodynamics. As a background, the picture on the right is really how atrial septal defects are. You're looking at it sort of right atrium open, looking straight on fossa, sort of the surgical view, and what you're seeing is superior sinus venosus, inferior sinus venosus, the secundum, which is the most common, a primum, which is a canal defect, a coronary sinus, which is very, very rare. But really, this is where a lot of transcatheter work is done. The way we think about this is that it's certainly genetic, and there's some sort of sporadic cases. But if you look at the bottom, it's 10% of congenital heart disease. It can be multiple defects. We look for veins, and then we have to look at pulmonary hypertension. I'll walk you through this in a second. So here's the case. The 28-year-old woman walks through progressive shortness of breath, fatigue, no hospitalizations, doing fine, went through college. But now she's sort of slowing down a little bit. There's no history of syncope. Someone said your heart's enlarged. She's euvolemic on exam. Her SATs are fine. That's very important to know. She's got a systolic ejection murmur and a loud P2. Here's her echo. This is a congenital echo. So heads up there, apex down. This is the right side of the heart. This is the left side of the heart. And you really can't see an ASD on 2D, but this is another way to look at it either. So we'll get some more imagings. This is, again, looking at it with color flow. Still can't see an ASD. So we're looking now and say, well, we can't see any flow. So where is this ASD? And this is why imaging is so important when we evaluate patients with shunts. What we did see was TR. She had TR velocity of roughly 4, so an RVSP of about 60. And here's subcostal imaging, and this is key in congenital heart disease. It's trying to look at the heart in all different formats. And what you'll see now, right up here, is this anterior superior ASD on a subcostal view. What you see is on the right side is the right side, this is the left side, and what you're seeing is a defect up here, and there's left to right shunting across that. So we found this finally. What we found was anterior superior defect, the secundum defect, left to right shunting, right heart's enlarged. There is some concern for pulmonary hypertension. LV is fine, and we'll walk through this a little bit. Why does the LV? Why do we even consider the LV when you think of adults? There's no pericardial effusion. Now, what we didn't see were pulmonary veins, which is why we went to an MRI. And on this image that you see this sort of anterior superior. It's an off-axis sagittal view. Here's the defect, and you can see the right heart's enlarged. But the function's okay of the LV and the RV, and we did find that the veins are returning normally to the left atrium. This is important to understand because with this defect, the differential comes into is it's a superior sinus venosus defect. It looks very much like that, but I won't get into the granularity of that. But the pulmonary veins were fine, and we took her to the cath lab. So I'm going to put my sort of hemodynamic hat on, and this is, I know we're in an interventional cath conference, but this is important to know. Why is this important? Because in shunt defects, it is tremendously important to understand what the PVR is. This patient's PVR was roughly about 5.5, 5.8. A QPQS was 1.8 to 1. We did a nitric challenge. QPQS doesn't change a whole lot. The PVR changes some. But here's the important part of this is why I was saying the left heart plays a role in this. Her mean PA pressure is 56. Her wedge pressure is 8. We challenge her in the cath lab, and we actually do not see a change anywhere on the left side hemodynamics. And this is important to know, is that the left heart hemodynamics are not changing even when we're challenging her, which basically means we're not going to unmask any sort of left heart disease. Now, stay with me for a second. I'll walk you through this a little bit more. Why does this all matter? Well, this is why we look at indications. So now I'm going to wear my sort of indication hat on and say, well, why do we even care? Well, we care because it's left to right shunting across a defect. There is volume effect on the right heart. We've seen this, right heart enlarges, but then there's an effect on the lungs, which basically means you can have pulmonary hypertension, your PVR can go up. And what you develop down the road is not just pH, but then this blood has to return to the left side of the heart at some stage, and concerns about atrial arrhythmias. And is there even any improved survival in adults with ASDs? And we all want to run to the cath lab and close it, but is there any benefit? And that's really where we're going to get into this. Here are guidelines. This is from 2 years ago, roughly 2.5, 3 years ago. And when you look at this, what they basically say, the ACC says, these are your indications to close an open defect, open ASD in adults, is that if there is right heart enlargement, your QPQS is 1.5 or more, you can make a case to close it. In asymptomatic patients, asymptomatic 2A, asymptomatic patients, right heart enlargement, but you've got to start thinking about pulmonary pressures. And why is this important? Because now they're getting into the actual numbers for pulmonary hypertension, something that we don't often pay attention to, but this is in the guidelines. Class 1 indication, again, look at the volume, look at the QPQS, but look at pulmonary vascular resistance, look at PA pressures before you close it. So this is important to understand that when we go to the cath lab, we're not just looking at closing the defect, we're actually paying attention to hemodynamics. Now, stay with me for a second. Is what we also see here is they get into the granularity and basically say, well, your PA pressure starts going higher, your PVR is going to be more than 1/3 of your systemic vasoresistance. Don't go there. Try not to close this. And if there is Eisenmenger's, right to left shunting, PVR is too high, absolutely not. That's not something you should be closing. So, point being that hemodynamics plays a big role in this. Now, I'm going to walk you through this a little bit because this is an important slide to show again from the guidelines. As we're looking at ASDs, we look at shunt direction. Don't go to the right of this. This is not something you do not want to do. You do not want to go into Eisenmenger territory and into shunt reversal. If that happens, that's a problem. You don't want to touch these. These are not something to close. But if this shunt is open and hemodynamics tell you that your PVR and PA pressures are okay and there's functional impairment, then yes, you can take them down a cath lab closure. However, this wasn't the case 10 years ago. Now there is a case being made that if you still have PVR changes in an open shunt and your PA pressures are high, you can go down a pulmonary hypertension route and then figure out if you want to close it or not. This is 2B. So stay with me for a second. Don't get into the granularity about how to handle this. This is important to understand, and I'll tell you why. So what are the indications now? Well, same thing, shunting, right heart, symptomatic, functional impairment, pulmonary hypertension. What about LV function? Do we care about it in a 60-year-old? What about paradoxical embolism? What about some pulmonary hypertension or atrial arrhythmias? And is there any survival benefit at all? Is there any survival benefit at all? Well, the European Society of Cardiology came up with a more granular document. And really what I want you to focus on is down here is LV dysfunction. They actually bring in LV dysfunction. They basically say if you go to the cath lab, you've got a balloon test, and you actually got to figure out, you're going to occlude the ASD in the cath lab, and you will see what will happen to the shunting and what will happen to left heart hemodynamics. They also talk about that, well, if your PVR is 3 to 5, or if it's more than 5, you can actually go down fenestrated closures. They get a little more granular with this. They also talk about paradoxical embolism, that it has to be cryptogenic. No other cause, yes, you can go ahead and close it. But what that means is this, basically, that when we think of shunt defects, it doesn't matter about ASDs or VSDs. When you think about shunt defects, you have to think hemodynamically. We have to say, well, if there's no pulmonary vascular change, it is safe, yes, close it. If you're on the right spectrum of this, is Eisenmenger's, don't close it. But what about all this, right in the middle? And that's where the European Society of Cardiology sort of became a little more granular. And since then, there have been a little more data. And what they've basically said, if you walk down here, is that think about not just the shunt, not just the right heart side, think of embolism, think of LV disease. And if you have PVR that's elevated, then treat it. Treat it, and if you can treat it and it gets better, you can make an argument of closing it with a fenestrated device or a fenestrated surgical closure. But look at this, it's still 2B. So it's, again, this wasn't in the guidelines 10 years ago. This has sort of raised its head over the last few years. So what this means basically is two other things. Well, what about atrial arrhythmias? We haven't heard this. We see a lot of adult patients with open ASDs with arrhythmias and flutters and PIP. But what about them? Should we just go ahead and close the defect? And is there still any, we haven't heard survival yet. Well, this is a very interesting review. And all I want you to pay attention is to this in the middle. This is all age closure. This is closed before 25 years of age in ASDs and PFOs, but mostly ASDs, and then closed after the age of 40 years old. The prevalence of post-procedure atrial arrhythmias is as high as 60% 10 years out if it's a late closure. The later you close it, the chances are that you may or may not end up with atrial arrhythmias, and that is something that we just haven't paid attention to. Is it earlier the better or not?
2 minutes.
Yep, got it. So what about survival? Well, survival hasn't been shown to be beneficial at all. Its survival has been similar between adults with ASDs and adults with no ASDs, so no benefit in survival. So what does this mean? What about patients with some pulmonary hypertension? I'm going to finish here with just two or three things. One is, this is your gray zone. A lot of patients fall into this gray zone. They have a little bit of pH that's elevated, PVR that's elevated. What do we do here? Well, here, over the last couple of years, there's now, and this is too granular, I won't get into this, is that you can actually go down pulmonary vasodilator testing. You give them targeted drugs, you bring them back, and then you close the defect with a fenestration. This is raising its head more and more and more. Again, Contraindications, no symptoms, no significant shunt, no right heart enlargement, no embolism, Eisenmengers, don't do it. I'm going to end with evaluation. Evaluation is imaging and hemodynamics. And this is more for my cath colleagues, is rims in secundum defects are tremendously important. We got to look at rims. If it's less than 3 or 4 millimeters, think twice. We can certainly do this. Look at the size of the defect, the rims, as I said, pulmonary hypertension, the veins, and then hemodynamics. Now, in the cath lab, when we're in the cath lab, we can use TEE or ICE. We can do balloon sizing. I always say you got to look at the defect, occlude the defect, repeat your hemodynamics, look at the left side, then decide what you want to do. So when you go back to this patient, she certainly has a PVR of about 5. We actually treated her with pulmonary hypertension therapies, and then we took her for closure. I'm going to end with pulmonary veins. Pulmonary veins basically means you have to look for them with ASD, CMR or CTA is needed. And if you find them, then they need to be treated. I'm going to end by this, basically saying when you go for transcatheter closure, it is primarily secundum defects. There is some data for sinus venosus, and I'll show you that for a second. But if you cannot close it in the cath lab, it is okay to give it up. I have seen a lot of cath doctors, a lot of my colleagues. So one of my friends are there. So it's okay to call your surgeon, and all your surgeons look like that, Babar, by the way, just so you know, you can call them if it's running into trouble. And the reason I say this is because these are big devices that go in adult patients. And look how close it is to aortas or valves, and they can cause erosion. So be careful with putting large devices. It has been described. This is sinus venosus defects. This just came on the market. This is Shakil Qureshi's data from the United Kingdom that you don't necessarily have to go to the OR. I will not recommend this at this point in time. This is not in guidelines, but you can actually put a stented SVC and let the pulmonary veins flow back through the superior sinus venosus defect into the left atrium. So this is raising its head now more and more. I'm going to end basically saying that, yes, it's a simple defect, but when we as adult congenital docs think about it, it is not just closing to the cath lab. It is really imaging, it's hemodynamics, look for atrial arrhythmias, look for the left heart, look for pulmonary hypertension, and then we sort of go from there. So I will end there, Usman. Sorry, it was a sort of a rush talk, but this is a bird's eye view on how we want to evaluate atrial septal defects.
Well, thank you so much. That was a great overview. And thank you for highlighting the pre-procedure planning and also the long-term implications of putting a device in. Like you said, it's not just getting the device in. So we do have Babar online. And Babar, what occlusion and
playing music
rhythm that Ali.
Can you guys hear me?
Yeah, Babar, I can see it, but I'm reading through it. Why don't you go ahead and just ask?
Yeah, so just on that case, and I can also see Dr. Masood Sadek, who has quite a bit of experience in closing adult with ASDs, and I would love to hear his thoughts also. But when you were doing the LV testing, wouldn't have you done it with the balloon occlusion so that you take care of the ASD? In fact, something that Dr. Masood taught me was to anybody above the age of 40, always balloon occlude and test the LV before you actually close the defect. So that's one. The second thing is there's quite a bit of data now out there on how, especially from India and from KK, that when you exercise these patients and if they're desat, that's a pretty red kind of a flag, and you would tend to not even think about closing them, even if at rest their hemodynamics are favorable. So do you guys exercise these patients on the cath table?
Right. So great questions. So and Usman, I don't know how much time we have, but I'll take the first part real quick because that's the easy one. The second one is a little more, it's a little more debatable. The first one is, I agree with Babar. I mean, whenever we think of adults with ASDs, we have to balloon occlude. We have to see what's going to happen with hemodynamics. So I completely agree. And it's only once we balloon occlude and see what hemodynamics, if hemodynamics change with balloon occlusion, then you have to reassess your plan. Absolutely. That's the other part, Barbara, you're absolutely right. There is a lot of data that's arising is when we cat them and we're looking at hemodynamics, we exercise them. I agree. We do. We try to exercise and we have bicycle ergometer that we use in the cath lab with a catheter still in there, and we look at hemodynamics. If they start desaturating, then I agree. We have to think twice about it. Now, the problem is, as I said, two things. One is, if you leave an ASD open in an adult patient, the data is that they will probably, and I think it's difficult to say what will happen, 10 or 20 years from now, is this risk of atrial arrhythmias. How do you manage the atrial arrhythmias? Because the atria have sort of adversely remodeled over 30, 40, 50 years of an open ASD. And that's the tricky part, is if you leave it open. But I agree. I mean, it's desaturations with exercise. We do it. Do I do it on every single patient? Not in the 20, 25-year-olds, but certainly in the older ones we do.
Dr. Ali, can I quickly comment?
Yes, Sagam.
Yeah, very nice presentation. I just had a couple of things because we work in a limited resource country and you don't have all that gadgets to go ahead. We normally actually evaluate these patients pre-operatively quite aggressively and looking at the X-rays, ECGs. And I think, as Babar said, we routinely exercise them. If we have a slightest doubt about their pulse oximetry, we exercise them. And if they are desaturating on 6 minutes walk test before they are actually taken to the cath lab, we don't take them to the cath lab. We put them on pulmonary vasodilators, reevaluate them after 6 months, and then decide whether you're going to catheterize these patients or not. And secondly, I think, as Babar has pointed out, it's our routine to balloon occlude all these patients who are above 40 years of age, obviously for obvious reasons, not only for pulmonary hypertension, but for also left ventricular function. And one thing which we have found very useful in these patients is looking at their diastolic pressures. I know these measurements are very important. You look at the PVR, but in our setup, these measurements can be very erratic. And I think because you're assuming so many things, you can go wrong. But I think looking at diastolic pressures, we have found is extremely useful. If you see a 25% or significant fall in diastolic pressure once you have balloon occluded an ASD, we generally would go ahead and close that ASD. Of course, we have created fenestrations on our own as well, not asking the company, but just doing it in the cath lab and then using that in certain patients. But I think that was my comment. Thank you.
Absolutely. I think what everybody is saying, as Barbara is saying, and Dr. Alex, you're saying, is that, again, hemodynamics and evaluating the left heart is very important, which is why I sort of showed that slide where if you look at the indications from the ACC AHA from 2018, there is really no mention of left heart hemodynamics. It's really the European Society that has sort of pushed it and said, well, and you have to balloon occlude, you have to look at left heart, and then you have to decide how you want to take it, close it or not. So, as you're right, I mean, you've been doing it for many years, but guess what? They're making it into they're bringing it into the guidelines now.
Hi, this is Bashir. I want to ask Masood and maybe Ali also, like if somebody, like we sometimes see someone in 50s and their ASD size is maybe 15 or maybe up to 20 or 18, and right side is dilated, PA pressures are kind of a borderline, maybe 45, 50. My first question is, do we need to close it at this age, that size? And secondly, would you be still in these patients considering balloon occlusion and checking before closing?
I think I would let Ali answer that, but I can answer that as well. But I think
absolutely. Yes. So again, the second part, Bashibai, is the easy one. It's we would do all sorts of hemodynamics, even if a 50-year-old coming in. We wouldn't go straight to closure. We would balloon occlude it. We would look at hemodynamics, pre-balloon occlusion, post-balloon occlusion. If you believe this, we would also do a couple other things. Barbara alluded to some of this. One of this is sometimes we'll give a fluid challenge in the cath lab too, just to see where things are. And then, as I said, if it's an older patient and there is any degree of, we think, pulmonary hypertension, we may or may not exercise based on what we're finding. So absolutely, balloon occlusion, left heart hemodynamics, underlying pulmonary hemodynamics, pre and post is all important. I think that's absolutely important. Now, your first question was important because you said, well, if it's a 14, 15, 16 millimeter ASD that's open in a 50-year-old, should we close it or not? Well, again, it sort of goes back to everything else that I was saying, is a lot of it comes down to hemodynamics. If you have no PVR issues, no pulmonary hypertension, your left heart's okay, you're not unmasking any left heart diastolic dysfunction with occlusion, or then you can make the argument of saying, yeah, we can go ahead and probably close this. Now, if you do see that gray zone that I showed where your PVR falls into that sort of 5-ish area, then you have to start thinking that do I need to treat this with pulmonary vasodilators first, see if that comes down, which is now being called the treat to close approach, which again hasn't made its way into guidelines as yet, except the European Society. So lots to think about. And again, the flavor of this I want to get, and I'll stop here, is yes, it's a simple defect, but those of us who sort of think hemodynamically, and all of us do, we always want to think about it in multiple different ways before we just want to close it. So,
thank you.
Just
I think, Usman, we have to
For
move.
a quick comment as we wrap up.
Sorry.
So I was just going to mention that the significance of arrhythmias in the adult population. Babar and I have shared patients who've come in on AFib, and the compliance with balloon occlusion is completely different in sinus rhythm versus AFib. But great talk, and unfortunately we are short of time, so we're going to keep moving on. I believe we have Athar Qureshi on the line as well. Athar, are you there?
Yes. Can you all hear me?
We can see you, we can hear you. So Dr. Qureshi is a medical director of the cardiac cath lab at Texas Children's. He's a professor of pediatrics at the Baylor College of Medicine. And he is going to be talking to us about a very important topic, which is tips and tricks of transseptal puncture. And so, you know, with more and more structural cases, transseptal techniques are extremely important to know and to utilize. So over to you, Dr. Qureshi.
Can you see my slides and still hear me?
Yes, we can.
Okay, assalamu alaikum, everybody. Thank you, Usman, for that kind introduction. And I'd like to thank Dr. Hanif and Babar Hassan for the invitation to speak today. By way of introduction, I'm a pediatric interventional cardiologist. I'm also an adult congenital interventional cardiologist, and I do some structural heart disease as well. In the interest of time, I'm going to keep this talk hopefully relevant and simple on really some tips that and tricks that we have learned along the way. I will not talk about complex congenital heart disease, for example, the Fontan or atrial switch patient, but really focus on those patients with a normal septated heart that are undergoing structural intervention in the adult world. These are my disclosures, and none of these disclosures are relevant to this talk in particular. So the objectives, I'm going to go over a step-by-step approach to transseptal puncture, go over the relevant anatomy, and go over some tips that we've learned for some challenging transseptal puncture cases. So this is an article, if you all haven't read, there are actually a couple of articles in this talk that I have a lot of animations from, and both are from JACC Intervention. This one was from Al-Huli and his colleagues from 2016. And as you can see here, you know, transseptal puncture is not a new procedure. This is something that was done in the 1950s, initially for hemodynamic assessment. And really its utility has grown over time. It was actually popularized in congenital heart disease by Dr. Mullins, who is still alive and is still is a professor emeritus here where we work. And from then on, you know, the first indications from an interventional standpoint were for percutaneous balloon mitral valvuloplasty. In the late 1990s and early 2000s, we saw its use for pulmonary vein isolation, but I'll also add not just for pulmonary vein isolation, but for pulmonary vein interventions, as many of those procedures, initially, many of those patients would develop pulmonary vein stenosis. And of course, left atrial appendage came along, LVAD devices, and as more and more prosthetic mitral valves were being implanted, paravalvular leaks were being tackled in the cath lab. And of course, you all are more expert at the mitral clips than I am. And then mitral valve and valve implantation, which started in the late 2012 onwards. So I'm going to go over some equipment first. There's many different sheets that can be used for transseptal puncture. There are these variety of sheets with fixed curves. There are the steerable sheets. Agilis is one of them. These are very, very expensive sheets. Even here in the US, we really think twice before we take them out. So there are some tips that one can learn from the cath lab from experience that may avoid the use of these sheets. Although in many instances they are very helpful. And of course, the BRK needle, safe step wire, and there's radio frequency needles also available. I'll end my talk in the end if you hang around for a technique that we've been using that is really not expensive at all and really helpful for a lot of these difficult transseptal punctures. So my talk doesn't contain much data because there's really not a whole lot of data about transseptal sheets in terms of how they can decrease time, But this was a nice randomized trial from Japan, and you can see here, using the steerable sheet, they reduced the procedure time and the total RF duration significantly. Our sheath of choice is the Mullins introducer sheath, and perhaps that's because we are stewards here of the CE Mullins Cardiac Catheterization Lab, but this is a sheet that's really, really used worldwide and comes in a variety of sizes. So this is our real go-to sheet, but you can use any transseptal sheath that is handy to do these procedures. Access, I'm going to skip over this in the interest of time, but one of the things that many of our patients who undergo procedures have undergone multiple catheterizations from the femoral vein, and they may have right femoral venous occlusion. In that case, one has to perform transseptal access from the left side. And so this was something initially described by Dr. Mullins, and it's a very simple technique. If you bend the thorax to the right, what you're able to do is, you can see here how the SVC and the IVC are in a line, but if you're coming from the left side, you're not able to engage the fossa ovale with your needle without bending it. And bending it is fraught with its own set of problems. So if you actually bend the thorax to the right, that allows the plane of the atrial septum to be more perpendicular to your needle. So this is a trick that we all learned from Dr. Mullins and certainly has come in handy. This is again that article from Al-Houli et al. And I think many of you have seen this. I'll skip over it in the interest of time, but there are specific transseptal punctures sites that are very important to facilitate these interventions. And they'll really cut down on procedure time, and more importantly, they'll access the intended area of intervention in a timely fashion. This is that same article, and you can see here for percutaneous mitral valvuloplasty and valve-in-valve procedures, generally a posterior and slightly central access is good enough. But if you want to do a mitral clip, you really need height there, as you can see here, to get to that mitral valve. And so a posterior and superior location for transseptal puncture is the way to go. Paravalvular leaks come in all shapes and sizes on the mitral side. They can be lateral or medial. For a medial puncture, you also want to go high, posterior and high, and for a lateral puncture, going somewhere in the middle usually suffices. For atrial appendage closure, a posterior and inferior transseptal approach is really what you want to achieve. And again, this is best done by echocardiographic guidance along with fluoroscopic guidance, and that allows your system to be coaxial towards the left atrial appendage. And for pulmonary vein isolation, remember, the pulmonary veins are a posterior structure, so the way that our EP colleagues get into them is they can use deflectable sheets, but generally if you access this area from a slightly anterior approach, and the emphasis is on slightly because we don't want to be close to the aortic valve, then that's a good way to access these pulmonary veins. So one of the things that I do, and again, this also depends on the laboratory that you're in, whether you have biplane fluoroscopy or angiography capabilities or single plane. But at any rate, even in a structurally normal heart, the heart can be shifted depending on what's going on in the lungs and with the cardiac pathology. I always find it helpful on difficult transseptal punctures just to take an angiogram. And if you take, this is just a picture showing a pulmonary vein angiogram, and if you take a subsegmental or segmental pulmonary vein wedge angiogram, pulmonary artery wedge angiogram, you see the pulmonary vein opacify, and you'll see the plane of the atrial septum nicely, both in the AP and lateral projection. You can also do a power injection. I'm going to skip over this in the interest of time, but this is a gentleman who had left upper pulmonary vein atresia, and you can see he has got a severely engorged left lower pulmonary vein that's taking his entire left-sided cardiac output. You can also do a power injection if you really want to see the plane of the atrial septum. These are a couple of illustrations showing that if you have single plane, the RAO projection and LAO projection, the LAO projection is what we use also for ASD closure. And you can see here, it really separates the right atrium and left atrium really nicely. You can also use an RAO projection. And the key is here, use these fluoroscopic outlines of the aorta and the ventricles as a guide. And you can also put a pigtail catheter in the aorta. For difficult transseptal punctures, I do that. I put a pigtail in the in the aorta. I think it adds just a few extra minutes, but it is worth that time. This is just fluoroscopy to correlating with that, the procedure correlating with that anatomic description there. Brockenbrow needle. So this is the needle. You go in. Obviously, we all know that you can you aim the hub of the needle towards 5 or 6 o'clock. If you want to get a more posterior, then you're going to aim the needle. You're going to tilt the needle towards 6 o'clock, but otherwise 5 would suffice. And if you go upwards towards 4, that'll enable you to get to a more anterior approach. So this is just standard transseptal puncture. This is a 60-year-old gentleman who had severe. Actually, left upper pulmonary vein atresia that I recently cath, and we were able to recanalize that. And you can see here, after coming down from the SVC, we've engaged the fossa and angio. I always take a picture in the left atrium to verify that we are in the left atrium. You can see here we've stented that vein, and that's the follow-up. I'm going to skip over that. Echocardiographic guidance, I think, is very key in these procedures. If you are in any doubt, you can perform transthoracic echo. You can see here from a subxiphoid view that needle tenting the septum. This is a TE projection.
2 minutes.
Thank you. TE projection, where you can also see there tenting the atrial septum. I'm going to skip over this. Here, I'm just going to run this through quickly. This is just some of those steps. This is from an article from Russo et al. You can download this from the web if you'd like. But I think the key here is to, once you get across, it's very important to make sure that you actually transduce and are able to confirm position in the LA. What happens if you can't get across with your needle? Well, you can balloon with a coronary balloon and then upsize to larger balloons, as you can see there. And then as the balloon is deflated, you can advance your sheath over, or if you're using a coronary balloon, you can advance a catheter over to facilitate your interventions. Finally, because some of those sheets are very expensive, this is a technique that we've been using, the electrocautery technique. This costs nothing because this setup is available with our surgeons and our EP colleagues. You connect you make sure a grounding pad is on, and you connect the Bovie needle to the hub of the transseptal needle, as you can see here. On the cutting setting, and you can deliver 10 to 25 watts for 2 to 3 seconds. Here's an example where the septum was deviated here, and you can see here staining of the septum. The advantage of this is that for aneurysmal septums also, or thick septums, for an aneurysmal septum that you may be close to the LA with puncture, that electrocautery technique allows you to get across without tenting of the septum. And for thick septums, that you're unable to cross with a regular transseptal needle, it has been very useful. Once across, be very mindful. I immediately give heparin. If patients are already on a blood thinner, I think it is safe to perform these procedures if you understand the landmarks, both fluoroscopically and on echocardiogram. But I think once across, make sure you give a heparin. The other thing that we do, I'm going to skip over this, that all of our equipment is on a flush. So I think it's a good idea to, even if you don't have continuous flushes all the time, to hand flush your sheath and catheters when you're in the LA. Finally, this is a recent article by Simard et al. From JACC Intervention. It's a very nice article that goes over a stepwise approach of what to do when you can't cross with your needle or dilator. And some of those techniques I just briefly mentioned, where you can use coronary balloons, and of course, the radio frequency or electrocautery, which I really have come to like quite a bit. So to summarize, you really need to understand the anatomy of the heart. It can be variable, even in septated hearts for a successful transseptal puncture. Keep in mind site-specific transseptal puncture, and have a proper equipment available for challenging anatomy. And happy Independence Day, everybody.
Thank you for a very comprehensive talk, Dr. Qureshi. Do we have time for one question, or should we do those at the end of this session?
We can take just one question and then move to the next talk, please.
Okay, so I've got I think I've both Dr. Asad Pathan and Dr. Asad Khan in the panel. Question is, how often are you using intracardiac imaging or TE for transseptals, and what's your experience in terms of doing transseptals just on fluoro.
Yes.
So for me, all transseptals are TOE guided, all of them, 100%.
I think just one, let me.
That's been our experience also. I think most of them, almost all are now echo guided.
I can tell you, Dr. Asad Khan, probably, I'm not sure if he's here or not, but at
I'm
Taba.
here.
Okay, go ahead, please. Answer the question. You go ahead.
Yeah. So for routine mitral ballooning, it's just fluoroscopically guided. That's how I train. But if I have difficulty, I might do it like Athar mentioned, do an angiogram or go to PE. But if I know there are like anatomic changes, or if we're doing like we've done a few mitral paravalvular leak closures, those are all done under PE guidance. So.
Dr. Mahmood, there is one question here from the panel.
You couldn't hear the question.
With a lot of pulmonary hypertension, and you know, when the pulmonary hypertension is severe, the anatomy is distorted. So it's very difficult to find the proper position for the puncture. So what you would suggest about the tips and tricks for this distorted anatomy?
That's a great question, and sorry if I ran over. Sorry if I spoke too fast. But you're absolutely right. For pulmonary hypertension, the septum is bowing all the way to the left atrium, and you can easily puncture the back wall of the heart in LA. And for that, definitely we use echocardiographic guidance. Sometimes ICE. ICE is expensive, but definitely TEE. What I would do in those cases is we never use the transseptal needle with force. We always use it with either RF or the electrocautery technique. So with electrocautery, you just touch the septum with that energy and it'll go across. So you're not applying force, and you avoid that excessive tenting of the septum towards the back wall of the left atrium.
Okay, I think let's move Osman to the next talk, please.
Yes, absolutely. We have, Dr. Qureshi, fantastic talk. Obviously we're always limited in time. Otherwise, there's so many questions that we'd love to ask you. We have next Dr. Naeem Tahir-Khaili. Are you online?
Can you hear me?
Yes, we can hear you. So it's my pleasure to introduce Dr. Tahir-Khaili. He's a senior medical director at the Oklahoma Heart Hospital, also medical director of the South Oklahoma Heart Research Center. He is graciously going to talk to us about unusual and interesting structural interventional cases. So looking forward to your talk. Thank you.
So first of all, I apologize for my attire. When you all go to a general body meeting, I'm going to the golf course. So my group doesn't want to wait too long. So I'm ready to go as soon as we're done here. I apologize for that. But this talk is really designed to be a rapid fire, just kind of show you different cases. I know that some of the structural heart is being done in Pakistan, just to show you where we are, where we're going, and not really talking about a lot of tips and tricks and the interesting things. The other thing I would say is I'm in a private institution, very, very high volume, and do a lot of this, but I'm absolutely impressed by Ali and others' talks. And for example, for the ASD, I have never done a balloon occlusion and did hemodynamics on the table. I did do those when I was at Mayo Clinic and doing my training, but out in private practice, the cowboys that we are here in US, we do all of our things beforehand, and then when we go in, we pretty much made our mind and close that up. Now that may or may not be the right way to do, but I just wanted the audience to know that sometimes a quick ASD is a 30-minute case also. It doesn't, and only lucky people get to go to Ali Zaidi and Athar Qureshi to get that. Unlucky people come to me and get done quickly. No disclosures. So we're going to talk about several of these. I'm going to rapid fire. This is a 71-year-old. We're doing TAVR. So the sizing was, I'll show you, and I apologize for the busy slides. But if you look at the right side here, you can see that there's not a lot of calcium in the valve. And we were measuring about 23 millimeter as this thing. We went ahead and placed it, and that's the video of going on. And right about it looks perfect. As I come off of the cine, there's 2 or 3 PVCs come in, and there's forceful ejection. And without much calcium in there, I have my valve dislodged. So on the next video, you're seeing the valve in the descending aorta. So I pulled that valve back into the descending aorta, deployed it there, put a new one. This was 26 millimeter. And that's one of the things that can happen. When we were doing live case, somebody had asked if we do it under pacing or not. So the Edwards balloon expandable are always done under pacing. And God forbid if if the pacer stops capturing, this is what can happen potentially. This is something that Uthar would do a huge amount better than I would. But in Oklahoma, a lot of times our pediatric cardiologists do not do adult patients. This is a 22-year-old lady, very interesting, had a tetralogy of Fallot, and just to remind folks, it's a VSD with a pulmonary stenosis, right ventricular hypertrophy, overriding aorta. She had a repair done when she was about 3 months old, and had a pulmonary conduit. What that means is there's just a conduit sitting there, and there's open pulmonary regurgitation. About at 14 years of age, she had severe right heart failure, and at that point, that conduit was removed and a pulmonary homograft was put in. 7 years later, about 2016, 17, she came to me, and the pulmonary valve had now stenosed. Again, a very, very busy slide. The point is not to show you how to do this, but what can be done. So one of the big things to remember is the pulmonary valve and artery is right next to the aorta. And if you put a valve in there, then that could impinge the right coronary artery and left main coronary artery. So one of the evaluation parts is to go up and put a balloon in there, dilate it, and do an aortogram at the same time and look at the right coronary and the left main and make sure they're not getting impinged, in this case, they were not being impinged. A long case, got into the pulmonary artery, then put a covered stent in there, about 45 millimeters long, 22 big, CP covered stent. So now you're excluding the old valve. Those are not as stiff; they're more compliant. So we had a recoil. So put a Palmas shut stent on crimped it on a 22 millimeter balloon, put it in there, dilated it. Now we had a fairly decent landing area, and then deployed a 23 millimeter Sapien XT there. So she's 4 years out, doing well. Had a baby 3 months ago, so really excited. The family's very excited. We talked about paravalvular leak closure here. This is that came to me with severe paravalvular leak in aortic and mitral. She had those put in 2015. Severe anemia, severe shortness of breath. So I'll just point this out. This is a T image. You're looking at aorta here. This is the mitral valve, and you can see that the enteromedial area has a large leak here. And if you go over to your right screen, you can see this is the medial part. So this is a nice segue into from Uthar's talk. So obviously here, we're going to use an Agilis catheter, and we're going to make sure that we're pretty high on the septum, because we'll have to turn it back into the medial portion to try to get across that. We did that. This was not a simple one because the leak is pretty large. So actually had 2 wires down there, 2 multi-purpose catheters there, and then deployed 2 4 millimeter VSD devices simultaneously, which closed it off pretty well. If you look at the top right, this is where the leak was, and it's doing pretty well right now. Also had an aortic leak, which we fixed, and I can show that here. So again, this is other territories, but we do get some PDAs in adults, and most of them we really never really should close. And in this one, the QPQS was a little high, and I would still have been equivocal about it, but the patients and family were very, very anxious to get this fixed. So on the echo here, you can see the PDA. I went in from the right side, cannulated it with JR4, and then we have a wire all the way down into the aorta, going from pulmonary artery into the PDA, into the aorta, and took a multi-purpose catheter in there. And then this is a 6 millimeter by 4 centimeter amplatzer ductal occluder. And that's it off. She's doing pretty well. So you can see this right here is the ADO, and this is a different projection. This is the RAO, this is the LAO, so you can see it pretty well there. This is an 82-year-old patient. I did a TAVR on him in 2016, had a unfortunate CVA after that, and then of course had a lot of coronary artery disease. So about a year later, had a heart attack. And interesting picture here. So on the left side, what you're seeing is LV, which is doing pretty good. But you can see this real nice leak going into a large pseudoaneurysm now. And a little more highlighted view right here. And you can see this, and you can see the aneurysmal area down here. So basically cannulated that with a multi-purpose, and this is a 6 millimeter VSD device that closed it off. Did very well after that. How are we doing on time? Okay, so the access issues with TAVR. When we started back, myself and Dr. Khalid Ghani, who's also from Pakistan at the Oklahoma Heart Hospital, we were one of the original investigators and partner and Certavi, so Edwards and Corval. So at that point, 50-50% access, so 50% apical and 50% groin. And again, our catheters were almost 28 millimeter, 28 French OD. And so we fairly quickly found out the apical is not the good way. So then we went to mini sternotomies and direct aortic access. For those patients who we could not go in through the groin. Then we went to open subclavian access, and we can go from common femoral vein in, go into the IVC, puncture into the aorta, and then take our valve up there, deploy it, come out, and put a ASD device and close that hole off. And nowadays, we're doing left carotid or right carotid access. So on Tuesday, I'm going to do one of that, and we'll do a valve and valve mitral and stuff like that. And this one particularly, what I wanted to show was, if you look in this middle slide, you see this calcification. The artery is decent size, but there's severe 360-degree calcification. So those are common iliac arteries. If you look at the left side, the external iliac artery has pretty severe too. So we have CSI device, but you know it's not approved to go up into the common iliac artery. I've had problems like this in now 2020, and we have lithotripsy, and so I've shockwaved it and then been able to get across that, but at this time we didn't a few years ago. And so we decided to do a percutaneous axillary subclavian access. It has a pacemaker and stuff. And this is the access, and you can see that. This is a degenerative and functional, very, very severe mitral regurgitation. And the patient also has a cleft. She couldn't walk across the room, couldn't lay flat. Not a surgical case. So those of us that do mitral clips, this is a terrible case. Right here, if you see, is a big cleft, and then you can see a flail A2 leaflet. Really not much you're going to be able to do this, but really without any options, we ended up doing a 4.5, 5-hour case. It was just difficult anatomy, difficult imaging and stuff, but ended up putting in 4 mitral clips. And so at the end, if you see right here in the lower area, the cleft area is still open, and there's quite a bit of leak from there, and this would still be categorized as moderate to severe. For people who don't put mitral clips in, this is severe to severe, but those people who put mitral clips, it probably still be called mitral to moderate to severe, because there's a lot of turbulence that happens when you put mitral clip. she was able to walk. I just saw her a week ago, 6 months into it. She's walking around. She can walk a mile and sleeps okay, does well. So we probably will go back in the future. And when we have TMVR available, we'll probably do that for native valves. This is a valve-in-valve. Again, this is a nice segue into a Thirstock. Common femoral vein. This is a person who had a bioprosthetic valve several years ago. The bioprosthetic mitral valve is now leaking. It's stenotic. And on the lower right side, you see a balloon there. I'm using a 12-millimeter balloon to dilate the septum. And then
Name 2 minutes, please.
We took a 26-millimeter Sapien Sapien valve and put that inside that. We'll show you on the left side. If you see, this is the echo, live echo. So that's the wire. And then you'll see this is, we're positioning our valve. And then here you'll see shortly rapid pacing. So we're doing rapid pacing and the valve is going to go up here shortly. Still rapid pacing. And so that's in now, and you can see the valve looks pretty good. This is a 3D image, and here is the valve on 2D and TE. Not much leak, looks pretty good. Where are we going next? So the holy grail is putting in a mitral valve in a native mitral regurgitation patient, not a calcified annulus, not a previous valve. So I've been working on this valve for some time now, a year or so. We've worked on bench testing. We've put it in some animals. This is only a couple of weeks ago. We have a cadaveric human heart and a beating heart model, and on the left side, and then there's a laparoscope in there. This is the actual valve. This is the laparoscope. This is what the valve looks like from the LV side. This is Alta valve. It is phase 1 study, hasn't been put in that study. So we're planning on putting it on 7th September, the first case in first.
And we are out of time.
Okay. 8 cases have been done. Epically, this will be first.
Can you hear me? We are out of time.
I can hear you.
Okay, go ahead. Go ahead. Sure.
I'm done. So this is something I asked Bashir if I could put this up here. So we have a foundation that works in Pakistan and in the US. And what I would like to be able to do is help support interventional fellows from Pakistan and the new graduates to be able to come to Oklahoma Heart Hospital and spend 6 to 8 weeks with us. We will provide them travel, lodging, boarding, food, and we'll try to get them the US visa. I have a lot of people come over the years, and we're able to get them visas after we send the US embassy paperwork. Our foundation is named after my mother. We have clinic, school, do other stuff and all that. If you all contact Dr. Bashir Hanif, Amber Mozam is my class fellow, Tayyib is my class fellow, or General Imran Fazl, or you can, I'm going to put this up on the foundation website here next week. And so we'll be happy to have these patients, these students here, and maybe help train them. Thank you very much.
Thank you very much. That's really exciting and inspiring work that you're doing. I want to open it. I have a couple of questions, but I want to open it up to the panel.
Maybe just we can take 2 questions and then we have to close the session because we're a general body meeting after this. And any questions from the audience or from the panelists here?
Regarding the ASD talk earlier, pulmonary hypertension assessment, we don't have inhaled nitric oxide over available. So any other protocols that you routinely use, which you can reliably to check the reversibility for, whether the PVR comes down or not. The other thing is our teaching was not to start drugs for pulmonary hypertension until you've documented with the right heart cath and stuff. We routinely do it. So just comments on that.
Yeah, maybe Babar or Dr. Masood Sadiq can tell because they are working here. like how to check the reversibility of pulmonary hypertension over here because nitrous oxide is not available. So what do you do?
Let Dr. Masood take it and then I can answer.
No, I think it's very hard to do it in our setup. But what we do normally is that we give them 100% oxygen. We take them to cath lab. They're obviously under general anesthesia because that's the only way you can give 100% oxygen. So because that's the only thing available. We did have access to injectable sildenafil. We occasionally get it. Sometimes we don't get it, and we have been using that as well in addition to 100% oxygen in certain cases, but otherwise it is giving them 100% oxygen for 10 minutes, sometimes even 20 or 30 minutes if you're still not sure, and then looking at the numbers again. Because nitric oxide is not there and you can't really use that.
I think one other very common problem I have seen in Pakistan is that a lot of patients who get an echo and their pulmonary PA pressure is maybe 45 or 50, and they are started on all these pulmonary hypertension drugs without any further workup. I don't know others are seeing or not, but I have seen quite a few of such patients. So I don't know what to do about that.
Yeah,
I think that's a very serious issue because we don't have people in adult congenital training. And I raised that question in Murray as well. I think now there are enough people with either treated or untreated adult congenital heart disease in this country that we need to establish this specialty as is adult cardiology or pediatric cardiology. At the moment, what is happening is that most of these patients were seen by us. We are still seeing them in their 20s and 30s. As long as we live, I think probably we'll continue seeing them. But I think this is a high time that we need to sit down, devise the criteria to have a adult congenital specialty and get people attracted from both pediatric and adult cardiology into this specialty. Otherwise, you're absolutely right. I see sometimes patients where these things are started without thinking as what would be the long-term implications, what are the side effects, how to monitor them, were they actually indicated or not. And I think this is something which is extremely important. Answering to your pertinent question, I think if you have a child with adult and atrial septal defect where your PA pressure is 40 or 50, there is a reason to start pulmonary vasodilators in them, but they must be evaluated by a person who is adult congenital or congenital heart specialist first to make sure that the evaluation is correct, and only then these medications must be started.
So I agree. Sorry.
I just wanted to make one quick comment to, and then I'll hand this back. I know I'm not on the panel. I'm just listening, but to Dr. Sadiq's point, I think it's very important what he just said. I mean, this is a problem here in the United States too, by the way, is that adult congenital has sort of raised its head over the last 15 years as its own specialty. The board certification only happened in 2016, which is 4.5 years ago. So you can just think about where the field has gone, where it's its own subspecialty now after all these years. So what Dr. Sadiq is saying needs to be taken on in Pakistan. So this is something that's certainly important. And to that point, just so I can make this clear, for adult congenital heart disease, you can come from either the pediatric cardiology background or the adult cardiology background. You absolutely. But the training at the end of the day, these are adult patients that you're taking care of. So you have to keep in mind that there is a whole realm of internal medicine and adult sort of issues that stem up, even though this is an underlying congenital heart disease. So just for the audience, I mean, yes, this is a subspecialty. Please recognize it. I'm happy to help it any way I can, but I absolutely echo those words, Dr. Sadiq.
From my standpoint, Ali, as an adult cardiologist, what I would tell you is, in the scenario that Bashir is talking about, if you took and again, don't have really data for it, but if I took 50 people like that who were discovered to have right to left shunt on a simple 2D echo, and now we have an ASD, I would tell you that a large percent of those patients, really the high pulmonary pressure is probably from a diastolic dysfunction or a mitral regurgitation that's been missed or a mitral stenosis that's been missed. So before you put them on sildenafil or something like that, I think they deserve a proper right and left heart catheterization. Make sure you go into the left ventricle. And if you have access to TE, take a look at the mitral, because a lot of times your mitral regurgitation will be missed on 2D echo. So it's just important to remember that part.
Thank you,
The other part I
Usman.
wanted to put was
Yes, I think
Let's close the session. I think we are.
Yes, we need to wrap up. Unfortunately, we're running out of time. And so I'd like to thank all the speakers, the panelists, and the chairpersons for a fantastic session on structural heart, really looking at a diverse set of cases and data. And, you know, it's a growing field in Pakistan, so we're excited that you're all involved in it, and there are more and more operators coming into it. And so we'll end the session here and go on to the general body meeting. Thank you, everyone.
Thank you. Thank you very much, everyone. Really appreciate Usman and all the panelists and speakers and everyone else. Thanks a lot.